Good afternoon, everybody. Thank you for joining the call. I think we're going to start so long. As people come in, we'll then carry on with the call. Thank you all for joining. I know it's 4 o'clock on a Tuesday. We appreciate you coming and logging into the call. Today, we're going to chat quickly, have a talk, from Michael Theron, the founder and clinical technical director for surgical navigation technology in South Africa. The topic we're going to have today is advancements and future directions in image-guided surgery. I'm going to do a brief introduction of Mike, or I'm going to try and do a brief introduction for a man of this man's experience. Mike Theron is a clinical engineer and surgical technology specialist with 28 years of experience in the medical technology field. His work spans neurosurgery, spinal surgery, ENT, and functional neurosurgery, including deep brain stimulation, planning and procedures. He is experienced in image-guided surgery, intraoperative MRI, robotics, and the integration of surgical devices within complex hospital IT environments. We'll give it over to Mike now to do the presentation, and thank you for your time.
Thanks for that kind introduction, Philippe. So, yes, welcome. Thanks for having me. Mike from S&T. We're proud to be partners of Brain Labs in the region. And my goal today is to give you a broader sort of perspective on the field of image-guided surgery, what that's made up of, how it's evolved, the technologies involved in shaping it today, and then a look at how those all sort of connect to one another in your operating theaters. I'm sure you've seen them around, and then a look at what's coming next. So it's quite a fast-moving space. I hope this gives you a clear sense of where we're heading. We're going to look into what makes up image-guided surgery systems, managing of patient data, then taking that into surgery-guided navigation systems, so image-guided navigation systems, and the tracking technologies that you're going to find with them. And then, as I say, interconnecting those devices in the theaters and technologies with buzzwords like VR and AR and robotics, etc. So let's take a look into the mechanics of the system and how that all works. Having an introduction to image-guided surgery, essentially, what is image-guided surgery? Well, in its most basic form, I think we can say that it's the concept of images of a specific patient that the surgeon can then look at and guide him to perform a surgical procedure on that patient. And then now, with updated technology, the ability to get new images in the theater environment itself. So essentially, if you had to try and define it, I guess we could say it's the use of medical imaging to plan and guide surgical procedures. And the technology has transformed those static scans, which we'll have a look at now, into this surgical environment, this virtual environment linked to a real-time navigation system that obviously gives the surgeon the tools that can bring all the images together, synchronize them into one sort of patient, perform 3D reconstructions on the data, and give him a better environment to now approach this procedure that he has to, and then formulate a plan, obviously with inherent benefits, going in and out on a single path, with better outcomes and more precision. So, if we delve back deep into where this technology's come from, well, that was a case of images being on a light box not too long ago. And those images would have been shot, 2D images shot in sequence, and the surgeon would have a look at those images and try and formulate a plan in his head of where those images were, and based on the patients that's in front of him, and then he could use those images to try and target the anatomy. So we could say that doctors used to study film on flat light boxes, and now we're actually stepping inside that data. And what we could see then is a fraction of what is available today. The digital light box environment, let's call it, is this space, a kind of a virtual reality space where the surgeon's images can move around and he can better orientate himself with the patient that he's now going to go and perform a procedure on. So it's, kind of like any of us would check a map before we're going out on a long trip, and we want to know which road we're going to travel on, and we would like to know if there are going to be any obstacles and what we'd like to see and what we'd like to avoid, etc. Formulate a path and then go and take our trip. And so in the same way, using a preoperative image-guided surgery system allows this surgeon to assess areas of interest, spot critical structures, find optimal pathways, plan exactly where his incision needs to be. He can then set an entry and a target and a pathway and review that pathway like he's never been able to review it before. And then, of course, save that pathway and take it now into theater and either use a navigation system or link it to a robotic system that will now execute that plan that he had formulated. So let's take a little look at some of the benefits, inherent benefits of using image-guided surgery and navigation type systems. And the first one, of course, is this preservation of functionality. The outcome for the patient is inherently so much better, especially when you are moving around in the brain. You need to know where can you go, where can you not go. We want to preserve function. We don't want to go through tissue that doesn't need to be transversed, etc. So the risk reduction is maximized and lowers the complications that could happen in this environment. Now, some of the data is visible data like scans, etc. And there's certain types of scans that we, with the naked eye, wouldn't be able to see this information. And an example here you can see are these DTI fibers. Essentially, through imaging water particles, we can look at how those water particles are affected by electrical current flow. And with an AI engine, it can compute pixel by pixel where those currents are flowing within the brain and essentially give us the telephone cables, the communication channels of the brain. And if those channels are linked to movement or sight or one of the functions, the surgeon needs to preserve those and he cannot go near those areas. So we're giving him a lot of information to formulate his plan and his surgery to avoid areas that he doesn't want to and, as I say, preserve the function of the patient. Another inherent benefit definitely is shorter surgery times, and it's the same back to the map analogy. If you know where you're going, you'll get there faster. If you spend your time messing around and not having a sense of direction, then it's going to take you longer to get to where you need to. So again, precise navigation, precise access to the patient with minimal adjustment. It just works well with the surgical team. The whole workflow is streamlined. And essentially, at the end of the day, there's a inherent physical and health benefit to the patient, but also a financial benefit in that surgery times can be shorter, anesthesia time can be shorter, etc. Less complications. Hopefully, things like recovery are quicker, etc. Another inherent benefit that you may be aware of or may not be aware of, but in the spine and orthopedic surgery space, there's a lot of intraoperative imaging that takes place because in that environment, surgeons need to know where the anatomy is. It's not just like when we're navigating a head and the head's in space. This is now bone anatomy deep inside the body covered by tissue and organs, and the surgeon wants to know where that anatomy is, so that there's more and more of this imaging in theater. And as that imaging gets more and more complex, especially with the advent now of these 3D cone beam type C-arm, cone beam CT C-arms that are coming into theater, they're firing a lot more radiation. So in that space, the surgical team either needs to cover themselves in lead vests and thyroid protectors, etc., and stand with that weight while there's screening happening intraoperatively, or with the use of a navigation system that can compute that space, that can track a patient, that can link up that digital environment. We can take the images while the team's out of theater and then not have to take more images as we superimpose instrumentation and implants, screws, etc., on those images and take away the need to do more sort of intraoperative imaging. So that's just an inherent benefit in the sort of 3D imaging intra-op space. And obviously with radiation, we must never forget that radiation is cumulative. You don't want to expose yourself to radiation unless you absolutely have to. And any radiation you get is cumulative. So the less, the better. But that deep into, as systems get more and more advanced, I'll show you shortly some more advanced imaging machines that then are able to image the patient without humans present. We can start to, through this deeper integration, just reduce that risk even more and more for everybody. If not mostly the patient, who doesn't have to continuously be irradiated just to have updated images. So let's take a look at how this 3D navigation works. We've got these images. Essentially, it's compared to using a map many times. As I've hopefully shown you, there's a software component and a hardware component to this, and it's a 3D environment. And so when we look at maps and we compare navigation to maps, well, the Mercator view might work well for maps, where for those that don't know, the Mercator view being a spherical Earth has been taken and flattened out into a 2D map that then can be used to navigate the surface of the Earth. Well, that X and Y might work perfectly for the Earth's surface, but in surgery, we need that Z value, and we've got to go 3D. We need that third dimension. So essentially, with just images and a 3D space, we have what we call 3D navigational or orthogonal views. And essentially what's happening is that they've set this axis, the center axis of the body, as a starting point, and we have images that move down the axis of the body perpendicular to the axis. And so they're broken down into what's called axial, sagittal, and coronal. Axial being the view that, as I say, goes down the axis of the body. That's this red line, as you can see. I've called it axial, and that's essentially an image going through the body down its central axis. Then we have the sagittal view, which then moves through the patient's body going from left to right. That's this green line. And so as this green line moves either left or right, which is our X value, so we would see the images at that point. And then, of course, the coronal being the front to back. So moving in 3 dimensions at once, we can navigate to any point in this 3D space. And it's the basis of all sorts of machines working around in 3D space, from 3D printers to CNC machines to now, as you see, image-guided surgery. And this gives the surgeon this environment to formulate and plan for what he anticipates to have in the theater environment. Add that now, this multi-planar, call it reconstruction, into a navigation system, and we start to have fancy software that can now give the surgeon this moving, immersible environment where he can have images correlating with one another, intersecting, 3D models, objects being built, digital assets being created, and just giving him this visualization of anatomy from multiple perspectives, and like he's never sort of seen it before. Just improving his understanding of crucial structures, giving him the environment to formulate a plan like he's never had before. So looking at this data that gets presented to the surgeon. I think someone's on. This initially, as I say, is the software environment. Now, I don't know if any of you have ever looked on a PACS folder for a specific patient, but there is a lot of data in there. Now, if you look at that from the surgeon's perspective, who just wants to get some images to formulate a plan to perform a surgery, he's got to first and foremost get through all those images, find out which ones are actually relative, then bring them all together, the ones that are relative, and make them one, so that he can now formulate his plan based on the different types of images he has and what he can see in each of those images. So this data needs to be managed, and it requires this simple environment. And so what our software initially does then is bring this all together in an application where we present the data easily, try and pre-process that data with artificial intelligence as much as possible. If the surgeon wants certain anatomical models built out of the data, we can set the software to do that. And so start to build this kind of digital twin, this, like, think of a gaming environment where you're in the game, you have the immersive world, and then you start to build assets. And so as we build objects and plans and things, we link them all to this digital data and create this digital twin of the patient, where the surgeon has this virtual reality that he can now plan, rehearse, collaborate with his colleagues, decide on a surgical plan, store that plan, and then go into theatre and perform it. And obviously, along the way, our software needs to interact whatever planning and data we do with the various devices that we may come across, be that export to a cell phone for viewing, or onto a microscope for viewing, or interface with another piece of equipment within the theatre, or back onto the PAC server. And then, of course, also at the same time, link this system to something like a hospital information system, so that the right data can be fetched at the right time, with lots of intelligence in the networking, so that we've got prefetchers that can work and deliver the right data to the right theatre if that's what's required within the environment, sort of on an HL7 protocol. But essentially, this creates this digital twin of the patient and provides this virtual environment for the surgeon to interact with the data. How navigation then fits on top of that is that we take this 3D data and track it in space as if it were something comparable to a GPS system. So like you have a GPS, has the satellites up in space, the satellites track the Earth surface, they track the car on the Earth, and then the map of the Earth is displayed with the car on the map, showing the surgeon where he's going. So as we've seen, patients are 3D data. The camera that we bring in, those are the satellites. The Earth has the reference points, which are then the patient's reference. The system instrument that the surgeon's actually holding is like comparing to the car, and the map is the patient's 3D scan. And so just like a GPS, we can now navigate around and find what we need to do on the patient. So there are different tracking technologies in that, what I just spoke about being the satellites. The one being this optical tracking with the camera, as you just saw, and the camera works in the infrared spectrum of light and generates and reflects light and tracks reflectors in that space. That's line of sight, and that's not always possible in theatre. So we have another tracking technology which we'll delve into a little bit deeper, which is called electromagnetic tracking, and that uses a field generator and electromagnetic fields, and I'll give you a nice technical understanding of how those two things work. So let's dive into the optical navigation system a bit further. And so what happens is that we have this infrared camera that comes into the theatre environment. It has these illuminators that shine out these beams of infrared light in the red spectrum that we can't really see with our naked eyes. But this light then goes down and hits a reflective surface on our instrumentation. And based on the geometry and location of those spheres, the infrared camera then identifies them based on their geometry and size and knows what they are, and based on a CAD model it knows where the tip of that instrument is, and then that instrument is superimposed over the patient data and shows up on either scans or 3D models, etc., showing its tip, its location, its trajectory, or we can do an extension of that trajectory, and so the surgeon can start to plan once he has that, what's called registration, registering the virtual patient to the real patient in theatre. But it is a line of sight. Let's bear that in mind. It's a line of sight system that the camera has to at all times be able to see the spheres on the pointers in order to track and navigate. Just like we have to have a satellite signal in GPS technology. Now, that line of sight has to be, remember, for the pointer that we just saw, as well as the tracker that's tracking the patient, because the system doesn't see the patient, it sees what is called the patient reference frame. And the reflective markers upon that frame and their layout tell the system what it is. And so in order to show where the instrument is, we need to know where the patient is. And we have to keep this channel of light, of visible light open, not visible light, sorry, accessible light, open to the camera at all times, and that's not always possible in theatre with the amount of instrumentation, the assisting surgeon, the scrub sister, the Mayo table. Once more and more equipment comes in there, it starts to get more and more challenging to keep this line of sight open. Another thing that we need to mention as well in the space is that whenever neurosurgery specifically is performed and the cranium's opened up and bone is opened, generally the neurosurgeon chooses to put the patient's head in what's called a Mayfield clamp. I'm sure many of you have dealt with those and seen them in your theaters. That's a head that rigidly pins into the bone of the skull and rigidly holds the patient's head in place while the surgeon does his neurosurgery. Now that connection to the Mayfield clamp is our point of reference for our navigation. So we rigidly attach a reference frame, as you can see here, onto the patient's anatomy. And then through that dynamic referencing, once the registration that I mentioned earlier, where we link the virtual patient to the real patient on the table is performed, once the system knows where the patient is, that frame is its point of reference and that frame cannot move. Now, we've got to keep the frame, as I mentioned, open, and we've got to keep the line of sight open, but also this patient is going to have 3 little pinholes in their skull. And if this was a case where, let's say, a surgeon in an ENT environment, or, for example, a surgeon performing a procedure in pediatrics where the baby's head hasn't formed properly and cannot be put in a Mayfield clamp, it's not always an option. Or someone, as I mentioned, ENT, having an ENT procedure, they'll be in the hospital for a few hours, can't send them home with these 3 holes in their head where the pins went through into the bone, whereas the patient having cranial surgery will recover in time and it'll be irrelevant. So it's not always possible to use the Mayfield clamp. And remember the line of sight. So the next technology we have then is this electromagnetic tracking. And in the electromagnetic tracking environment, the camera goes away. And what happens now is that we bring an electromagnetic field sensor into the surgical field. And this creates a 50 by 50 by 50 centimeter electromagnetic field in which it can track distortions to the field. Into that field, we send in then instruments with tiny coils wired into their tips. So it's a true trip tracking technology as opposed to a geometry tracking technology with our reflective spheres. Here we're actually tracking that coil in the tip of the instrument, and it's a non-invasive tracking technology from the patient's point of view, in that the patient's reference can just be stuck onto the skin, and as long as the skin doesn't move, we can now rotate the patient's head and move the patient's head around, or be completely non-invasive to either do something like a pediatric shunt or an ENT procedure, etc. But this doesn't require line of sight as long as the electromagnetic field doesn't get distorted. So it is susceptible to heavy metals. Any of the sort of beds that have got major round ring closed loop type handles, etc., made out of stainless steel can affect us. So generally we're looking for carbon fiber tables and things. So obviously heavy metal in that space does affect it, but it's definitely got its place where line of sight and pinning isn't an option. So those are our 2 sort of tracking technologies that enable the image-guided surgery. And now what I thought we can do is take a look at how we interconnect some of that technology into the theater space. We've got to integrate, the item I've chosen for today is the operating microscope, just to give you some insight into how, I'm sure many of you have seen those. They're getting really advanced. They've got major functionality, and that functionality goes hand in hand with the navigation systems. And slowly, as these things advance, we're getting a deeper and deeper integration between our navigation systems and these types of instruments like an operating microscope. So we've got our navigation system set up in theater. Let's just paint the environment. The surgeon's happily navigating. He's got his pointer in his hand, and now he's getting to a point where standard visualization is not going to help him, and so he needs to bring in an operating microscope. Now, remember our line of sight. He brings in that operating microscope and blocks everything that we're trying to track in our infrared environment, and he cannot see the frame, and the navigation is not working. And even if it was working, how he's looking through the oculars of the microscope, he now needs to see the images that are on the navigation system. And so we certainly don't want to end up in an environment now where the surgeon's navigating and his navigation system's not playing hand in hand with what he has, because he now maybe has to move his microscope out of the way in order to pick up his navigation pointer and then get the screen of the navigation to where you can see it and make sure the camera can see the pointer. So it does get rather challenging. And so we have a really advanced, as I say, interfaces to microscope. And let me just take you through what they essentially do for us in this space. So with the navigation set up, we can provide a tracking technology, that a tracking frame that can then be mounted onto the microscope. So now we don't need the pointer anymore. We can use the microscope as a pointer. Just breaking it down for you technically, how we actually use a microscope as a pointer. Well, most microscopes nowadays have electronic stepper motors in them. Through a process of calibration, we can calibrate the focus and zoom depth based on the crosshair that is visible in the ocular. And once that calibration is done, essentially that crosshair becomes a digital pointer. And so wherever the surgeon chooses to focus on with depth of field and focus and put the crosshair, so that point will correlate to a position on the navigation screen. But remember now, here we've used the head of the microscope as a pointer, but we still need to see the image that's on the navigation screen. So the surgeon, again, doesn't want to look away. So what do we do? We have now, as we see more and more of these scopes coming out, head-up display systems built into the microscope. So you can see there we can actually place a picture-in-picture into the ocular so that the surgeon can see what he just looked at with his crosshair correlates to these three intersecting, as we saw earlier, axocoronal sagittal images on the preoperative scan, and now he knows what he's looking at, and he can continue on as if it was an electronic pointer. But we can provide even more information than that because we have spatial information, because we've built objects within that space. So we can now augment his view. So not just show him what he's looking at, or not show him just a virtual environment, but take his real video image and superimpose on it the objects that we created previously. So like those fiber tracks, or like the tumor, or maybe a major vessel that he wants to visualize. So we can inject those into his live video feed. And then further than that, what we can do is, coming back to the navigation system, we can interpret the whole vision of what he's looking at as a single slice image moving through our data set, so that you get a complete perspective of what he's looking at in the 3D virtual environment. And so he can correlate those two together. Some other functionality that you also see in the microscope is stuff like the robotics function. So technically we can have a head in front of us. We could take our navigation pointer if the microscope was close enough, because obviously the robotics functions only drives the head in its aiming movement. It doesn't drive the head into the theater environment, but technically you could click on something and save it with the navigation pointer, and then click the function on the microscope and tell it to look and focus at the point you just touched, or we could actually get the microscope to follow a point in space. And then, of course, one of the fantastic new features that microscopes are doing for us is that because we've got a live video feed coming back to the navigation system, we can simulate how the brain is moving intraoperatively by taking what we have as original preoperative data, simulating what the microscope's now seeing, and correlating that shift, and then giving the more accurate sort of assessment of the soft tissue within the patient in front of us for that specific procedure. So quite a lot of functionality that's built into these devices, and we don't always see it. We see them there together, but we don't realize how much they can actually work hand in hand with one another. This whole world of visualizing this augmented reality is really going to become more and more immersive. And one of the products we're really proud to have in our stable, and we're going to see more and more of, are these sort of augmented reality type glasses, where you can, as I say, the pre-operative planning was done as this sort of virtual environment, and the surgeon could immerse himself in that environment with a computer screen or the microscope screen. Well, now we have these glasses where we can collaborate in groups. It really comes together in the space of hands-on training, collaboration with colleagues, just developing skills with one another, and creating efficiency, allowing multiple people to completely immerse themselves inside these models, plan, visualize, and obviously understand exactly what's going on. And that comes down to the patient as well. Ultimately, you could put these glasses on from a patient consent or complete patient understanding point of view. Once they see it in a 3D environment, they're really going to have so much more understanding of what the procedures are all about. So that's essentially virtual reality and augmented reality. One of the downfalls, as we saw, of image-guided surgery is that most of the time, the images that we're working with, if it's not in the spinal environment, as we saw, those are static images. And so we need ways, as I mentioned now, I just touched on it with a microscope, as we start to remove tissue within the brain, so the brain shifts, so our accuracy must be put off slightly. And what do we have to re-image that patient? Now, if we go back to MRI and CT, well, we then need to get this patient back to an MRI scanner, have them rescan, bring them back to this environment where we can perform this registration, and then now have updated images. But more and more, what we're going to see now are these sort of hybrid operating rooms where either, as I said, we have these cone beam CT type devices that can image the patient then and there, and we can continue on with the procedures, or we can start to interface to other devices in the theater. So, like for an example, in many theaters you have ultrasound, and these ultrasound Dopplers are brought in and surgeons can image intraoperatively. Well, that's a 3D acquisition. When the fan of the ultrasound is shot through space, it's actually a 3D fan in space. Again, bring it back to the navigation system. If we can track that Doppler, as you can see, we can track where that fan was shot in space. We can break that down into axial, coronal, and sagittal, merge that back with our preoperative planning, and then, like we see here in the scan in blue, there's a resection cavity. We can see how the brains shift and what resection we've done and what residual tumor there still is in that environment. So we're getting updated imaging at the time of surgery. Take that one step further is what we have. We've got systems around the country called iMRI theaters. That's intraoperative MRI theaters, where you have, as you can see in the bottom picture there, an MRI linked to the operating theater. So special anesthesia, etc. But patients with his head open can be put in a format that he can be then sent across to the scanner, new images taken and brought back to the theater, and they can continue targeting. Not always is tumor or different types of tumor or residual tumor visible to the naked eye, and surgeons need to re-update their imaging, especially in the case of low-grade lesions, etc. So that's where intraoperative imaging is going to start to become more and more of a prevalent technology as well. And then, of course, the buzzword that seems to be everywhere, well, as we've seen, using image-guided surgery software, we can visualize like never before, we can plan like never before, we can save these plans. And now we're starting to get to the realm of, if you've done all that preoperative planning, we can get to an environment where there's equipment that can execute that in a repeatable rate that's with favorable outcomes over and over again, and that's with something like robotic precision. But it's a case of a surgeon having to formulate the plan and then having the robot come in and assist with achieving that target seamlessly and as quickly as possible. And so either, as mentioned earlier, we might have robotic devices that then, once a patient's robotic imaging devices. So once a patient's is imaged and is registered in a surgical environment, rather than having to mess around with coming in and adjusting to get an imaging device to be able to be in the right position, this imaging device now knows where the patient is, and the surgeon can drive the imaging device from the navigation system and tell it, come and take a picture of this. Everybody steps back, this machine comes in, takes a picture, it leaves, the pictures get updated on the navigation system, and the surgeon continues working. Or with the case of robotic devices from an execution point of view, from a planned trajectory, the surgeon sets up, plans a trajectory, and then quickly and seamlessly this device can quickly come in and aim and lock on that trajectory, and the surgeon now has a working channel to go and execute his operation. Bring this all together, what we've seen today, specifically not the robotic side, but definitely on the viewing, imaging, planning point of view, and we end up in this place. And these are latest sort of technologies that are being used worldwide. This is a mixed reality spine surgery environment. And so in this space, the surgeon's got this augmented reality. He can come in with a 3D imaging device that's deeply integrated to his navigation system. He can image the patient, but putting on a patient reference frame through a very small incision or through some percutaneous pins, non-invasive, mostly non-invasive to the patient, very small incision, put the referencing on, register the patient, and then show his imaging, his plans, and the patient's anatomy without making a major incision. Through the drapes, he'll be able to see what's going on. And this can be, this technology will just start to augment into all sorts of spaces within the OR. Another point I've heard of this technology being spoken about is that crazy Mayo table that the scrub assistant has to deal with. And there are times when the surgeon's looking for a specific instrument. Well, this augmented technology has both video feed and projection technology. So we can analyze that Mayo table. We can have AI identify all the instrumentation. And when the surgeon asks for it, a light can or an arrow can flash and point out where that object is on the Mayo table, something like that. These are all accessible, technologies, and I expect we're going to see them in our operating space, contributing to that whole digital space, to this digital environment. So that's kind of all that goes into image-guided surgery. I hope you've got a better understanding of the software we use, why we use the software, what the software does for the surgeons, how we take that software, bring it into theatre, use it to, as I say, navigate around the theatre or around the patient in the theatre. And then obviously interface that data to other devices, use other devices to update that data, bring in devices like robots, etc., to make sure we get our execution spot on and repeatable. And then, of course, simplifying the environment with things like augmented glasses, etc. So, yeah, I'm going to end off there. And if there are any questions that I can answer for anyone or anything, please, I think, go ahead now, yeah.
I want to say thank you, Mike and Colin, for that presentation. That was very informative. I have learned a lot in a very short space of time. I was blown away with specifically the 3D augmentation that you're able to actually put onto the reality or the real images that the doctors are seeing. I've got a quick question and a set of questions that will follow that. My first question is, what is the accuracy percentage that you're working with?
So depending on the systems and depending, on how those systems are adopted, there's certain tolerance. So most of the systems are looking at sub 2 millimetric accuracy, but obviously when you set up and when you use these systems and obviously go through the learning curve, there are little nuances that the surgical team can do and the surgeon can do to really bring those numbers down drastically, and really get the system super accurate, And ultimately, there's what we call respect for that reference frame construct. You saw how our reference frame attaches, and we don't want assistant surgeons, they've got nothing to do, so they'll just rest their arm on there while they hold the suction. We don't want things like that happening. So but yeah, sub 2 millimetric generally. Yeah.
Yes, okay. That's very accurate.
Yeah.
I'm going to open it up to the group as such. I actually want to ask the engineers on the group if there are any clinical engineers that have seen live procedures using a surgical navigation system before. If anyone can just unmute themselves and maybe say if they've seen this type of system working in their institutions.
If I may make the point, Philippe.
Thank you, Colin.
I'm Colin Greenfield. I'm the Mike's business partner. We are currently active in well over 100 hospitals in South Africa. We offer two different forms of navigation, one on a rental basis, case by case, or many hospitals have our systems purchased and installed in their hospitals. I would invite, therefore, any clinical engineer who is interested in the technology to give us a call. We can tell you when and if we're operating in your hospital and invite you into theatre to demonstrate the system to you in a live environment. As I say, well over 100 hospitals in South Africa we work in on a daily basis. We do approximately 160 to 170 cases monthly within South Africa, all of them supported by our own clinical technicians. So at any point in time, if anybody would like to come into theatre, with the greatest of pleasure, Philippe has our contact details either by email or telephone. So if you want to get hold of us, with the greatest of pleasure, we'll arrange either a demonstration at your hospital if you'd like to see the technology itself, or an invite into your theatre when we're there to come and watch the technology working. Thanks.
I think I'd also just like to make the point that if you do perhaps have one of our systems installed in your hospital, please just know that we are more than happy. You see how enthusiastic we are about our technology. If you'd like to be upskilled in any way, and I'm sure your hospital groups will also appreciate it, we were happy to show you, where you could step in and play a role in the use of the system, and maybe loading data or doing certain checks, etc. But we're happy to share the knowledge. Yeah.
Sorry, the second question I wanted to add was, how does image-guided surgery impact surgeon confidence and decision-making during procedures? Because I presume there must be some sort of trust relationship with the system and the surgeon.
For sure, and the adoption of that trust, the surgeon, as we saw, the surgeon has planned in his head, based on what he has available to him, imaging-wise, where he needs to go. You now bring in a navigation system, and it gives him a different perspective. So a lot of the time, that 3D perspective gives the surgeon a great representation of the anatomy in front of him, and there are often times when surgeons say, "Oh, I didn't see that," or "I didn't perceive that," or "I would have only seen that when I got there," kind of thing. And so it gives them this environment. And there is definitely a period of having to prove yourself, but I think once the surgeon understands his role and how the technology works intricately, and everybody's protecting that environment, then the confidence levels are something that they rely on the technology heavily. Yeah.
Perfect. So I'm just going to check if there's any more questions. Also wanted to ask, what factors most influence the successful adoption of image-guided surgery technology in a theatre setting?
Okay, so yeah, look, there's got to be first thing is perceived benefit for the surgeon and the patient.
Yeah.
If they're not seeing that, then there's no point in bringing in a technology that's just going to possibly in the early days, while the learning curve's happening, extend theatre time a bit. You have to go through the learning curve. If they cannot see that perceived benefit, then there's no point. So first and foremost, the perceived benefit, but also I think the simplicity. BrainLab's very orientated around concepts like click efficiency and software fatigue. That you if you can click and do something in one keystroke, why would you have software that takes 3 keystrokes to do the same thing? So the software's got to be efficient. It's got to have kind of smartphone simplicity. You can't have these complex software things that you're trying to bring into this environment, and people are wasting their time trying to remember which menu did what function. So simplicity, and then of course has to have robust technical support to back it. You've got to be able to either have people there if you need them, or people that you can get hold of that know why the system is doing what it does, and no guesswork. This is a patient environment, and there are no second chances.
Life and death is at stake here, exactly.
Exactly, yeah.
Are there any other questions that anyone would like to ask?
There is a question there. There's a question there from Justin. Where is the sensitive patient data stored? Is it on the cloud or probably on a hard drive?
So initially the system obviously will retrieve the data from the PACS system. We can either do a retrieve from PACS, less and less we're seeing CD-ROMs or wherever they sent to us from the imaging devices. The system has its own internal hard drive, which then can be archived. So we can burn off the hard drive onto external storage, or we can push back to PACS and clear our local hard drives, or it can, it's all down to a hospital policy. Everything is password controlled, but mostly on the local hard drive. If we do a server-based installation, then it would be on the SQL server that's hosting it, or PACS, yeah. But that's the hospital's data. If it's in one of our rental systems, the system gets brought into the theatre, the data gets loaded, images are created, they're sent to the surgeon, and the data gets deleted. We don't store patient data off-site.
Thank you, Justin, for that question. Sorry, Jeff, can you see any other questions? I can't see the chat at the moment.
No, there's no questions at the moment.
Okay. Sorry, I think a question's coming
Here's
from
a-
Ronnie.
There's one.
What's
Ridzani
safety?
is asking, yeah, Ridzani is asking question, yeah, what safety checks or alerts are built into the system? Yeah, okay, he did join in a bit late, so he might have missed it. He just wants to know the safety, and I think you brushed over that, Mike, in the very early stages.
Yeah, so obviously there are various safety checks built into the system, but a system, let's just get out the way that a system cannot know if it's accurate or not. So that relies on the surgeon confirming the registration process. Once that is done, there are monitors. I mean, if something had to suddenly move the reference frame, the system would pick that up and an error message would come up and say, based on what the optical camera has seen, there could have been a movement. Please check to known anatomical landmarks. It has full recovery, so from a power point of view, if you just pull the power plug out of the wall, plug it back in again, the system will power on and go straight to a restore state where it'll say to you, there's been a power failure, would you like to restore where you were? And the system will restore to that state. And then furthermore, we can build into the system a recovery process. So in other words, if we're working and we now feel that that Mayfield clamp moved or something moved in that environment, we could have put in some locations that have been stored in a recovery plan, and if need be, we can execute that recovery plan and regain where we were. Yeah.
Mike, just another question from my side. One of the last points you talked about was the mixed reality.
Yes.
How far are we from seeing that happen, or is it already coming?
It's already released. So that BrainLab mixed reality is released in Europe. They've done, I think one site's done, if I stand corrected, but if you just have a look on LinkedIn, you'll see it there. Yeah, it's happening in Europe. It's coming fast. Yeah.
Okay, so it's a matter of coming through. Brilliant.
Yeah. But obviously, in our environment, we're in the South African environment. Nice to haves and need to haves are two very different things in our product line, and so we definitely cater for making sure that we can get our technology to anybody in South Africa, and that means that we pitch our technology at that level. We want the best of technology, but we don't need all the bells and whistles, as long as we can make sure that anybody, be they in a government institution or a private institution, wherever they are, they can get this technology, and that's key for us.
Are there any other questions anybody has? Mike, I have another question. In your presentation, you also mentioned about the 3D images, that's basically AI-infused images that you also have on the system. I wanted to know the AI data or data set that it's using. Is that live data that it's getting from like imaging systems like MRI, or is that infused in the system? Sorry, and excuse my...
Yeah, no. So that's our oldest AI, weirdly enough, as BrainLab. That's a 30-year-old AI technology. It's embedded, so it comes out of imaging. It comes out of analyzing pixel by pixel every single scan that we take. It's got anatomical information in there from 7 Tesla, and I think there's a 12 Tesla scan that they used in the machine learning process to know what tissue we are looking at. So whether it's bone, whether it's fat, whether it's water, how that tissue behaves in relation to gravity and the imaging directions, etc., etc. So there's a lot of intelligence in the AI to know what it is segmenting, and that segmenting is automatic. It's over 100, and the list grows longer and longer every month. But you can just you can just load up whatever you have, CTs, MRIs, all of it, and tell the system, I want the spine, I want the heart, I want the lungs, I want the vessels, I want the specific structure in the brain, and it will go and segment those all for you. And in fact, the AIs can actually be a worker on the hospital network. So it can just sit there monitoring PACS traffic. If it sees, oh, here comes a scan for Dr. X, who is a neurosurgeon, and it is a full head scan, well, Dr. X says we must grab that. It grabs the whole data set and it analyzes it, finds any anomalies, so it will be able to find if there are any sort of tumors, etc. And then no, Dr. X wants the skull built, the eyes, the optic nerves, etc. And then when Dr. X opens up the data, it's presented to him already, and there's his 3D modeling and everything done for him. All he has to do is verify it. Yeah.
Wow, that's brilliant.
Yeah.
Are you ever going to run out of processing power is my next question.
It is, yeah, it is quite intense that those new machines have got multi-core, multi-processing. Yeah, the bigger machines. Obviously, our bottom-end machines, we have different machines in our range. Navigation's navigation, if you really need to know where you are or what you're doing. If you need the advanced planning and that sort of stuff, then yes, you must buy one of the bigger machines that can handle that sort of data better, for sure. Yeah.
We have a question from Lefuna here.
Yes.
The question is image-guided surgery only available with BrainLab, or are there other brands available locally or globally?
No, there are many, many other brands. Obviously, a couple of big players in the market, names like Medtronic, Stryker, ourselves, BrainLab, other smaller players in the space. Some only do electromagnetic, some only do optical, some only really concentrate on the navigation system sides, etc. But the whole package and the artificial intelligence and what BrainLab's delivering is kind of a niche. It's really a navigation first company. But yeah, a lot of these technologies and a lot coming out of the likes of China, Taiwan, many of those, if you have a look on LinkedIn. But again, it's either a very basic black and white GPS to showing you where you are and where you want to be. And then, of course, there's Google Earth, yeah.
Depending on the system you want to use, yeah.
Yeah.
Great. Okay. Are there any other questions from anybody?
Yeah, thanks.
Thanks while we're
Thanks,
waiting.
Philip. I'm just unmuted.
Yes.
I think I just want to thank Colin for the information. I was just actually asking because Colin Teron, I work for Mike, I work for Medtronic. That's why I was asking.
I did too for many years. I think I was with we brought the first navigation systems in from Medtronic in 1998, but I give my age away then.
Yeah, all right. Thanks.
We have another question from Jason here quickly. It says, are surgical instruments able to be paired with a BrainLab navigation system?
Thanks, Jason. Yeah, that's a great question. So what happens is that we have frames, either trackable frames or, as we saw in the electromagnetic environment, coils that can be attached to the instrumentation. They need to be rigid instruments, obviously. We can't have instruments flexing if we're tracking them. And then we have a device that's called a calibration device, and we utilize that to register the instruments. So that could be something like a ultrasonic aspirator or a suction or a debrider or a drill. And once that device is registered, then the surgeon doesn't have to keep on going back to his pointer, for an example. Yeah.
Sorry, Mike, just a follow-up question on that. But
Yeah.
do you have, because I know, and I'm just asking this because I know if you calibrating, will the quality then be compromised, or you have selective instruments that are in the system? Or it's almost like take all?
No, yeah, thanks. It's a great question. No, so we don't calibrate with a pointer, for example. We calibrate with a specific calibration device, and that calibration device is like a digital verification device. So you can actually see this block of aluminium that has rulers on it and it has holes in it. And once you've calibrated your instrument, you can hold the object up to the camera and you will see the 3D environment with that object, and you'll see the 3D version of the pointer that you're holding, and you can then place it into holes, measure on the ruler, and make sure that that device is exactly where its tip says it's supposed to be, and you correlate the real device in real space. So yeah, we have a calibration device. think we've lost you again there, Philippe. Something with that microphone.
I think so.
Yeah, there you're back.
Can you hear me now? I think I need to get
Yeah.
AI infused microphone or something, Mike.
Exactly.
I wanted to say thank you to yourself and Colin for the detailed presentation, very informative. I wanted to ask, is there any last comments you'd like to say before we thank people and then log off?
There is just one other question that Justin has just posed.
My apologies.
Sorry, so I'll just read it out
No.
here. I know that the system uses infrared imaging technology. Does the system also allow for narrowband imaging? Both have their own advantages. While NIR allows for deeper penetration, MBI allows for better viewing of microvascular structures. Or does it just support infrared viewing? Mark, I don't know if you know of narrowband imaging.
No, but I would have definitely correlated to something like ultrasound. If there is a device and if it starts to show its use case in something like neurosurgery, that may be useful in finding vessels, etc., for maybe injection or something like that. But if it does have, I haven't heard of the technology myself personally, but if it does have its place and it is a 3D environment that can, it's a 3D data set, I don't see it being very difficult for us to track where that data set is in space and bringing that data set into our pre-existing data sets. It shouldn't be a problem because we're merging all forms of data. As long as it's the same patient, we merge based on the patient anatomy and what we can see in the images.
I think I'll leave the floor open for any more questions because I see people are still having a few questions. There we go. Just another question there, Mike. Shall I read it quickly? Narrowband imaging is more a technology used in endoscopy and is not used for real-time instrument tracking in space.
Thank you, Mr. Israel. Hedley will always know.
Excellent. I think that's pretty much it.
Yeah.
I'd just like to say from Surgical Navigation Technology and BrainNet, thank you very much. It's fantastic. We had over 50 people watching this presentation. Most grateful for that. Thank you very much to the Clinical Engineering Association of South Africa for having this forum to allow companies to chat about their products. And above all, thank you very much to clinical engineering all around the country for the fantastic work that you do in our hospitals. Frequently, we are in contact with a lot of clinical engineers at the various hospitals we work at. Greatly appreciate all the inputs and the work that you do. It is highly, highly valued. Thank you.
Thank you, Colin and Mike. Thank you for a very informative session. I also have to say thank you to Jeffrey, who's been handling all the background stuff for us at the moment, and making sure the presentation works and everything's working in the meantime. We also want to say thank you to all the people that actually attended the call. Thank you for taking time out. We know it's difficult at times to come through, and we really appreciate your time. And once again, thank you for the great presentation.
Thank you, everybody.